Right, so I'm on. Last time we left off, we were talking about the pelvis, and I think I just introduced the three bones to the pelvis, so I'll start there. When I think of the pelvis, what I picture really is the pelvis is a bowl that doesn't have a bottom to it. It's got an open bottom. So picture like a typical cereal bowl or something, a large salad bowl that the bottom is a hole as well. That's kind of the shape that the pelvis makes, the right and left. And back on the back side, the sacrum is the connection point, and this should the hole should actually go up. The sacrum is the connection point between the two halves of the pelvis, and as it comes toward the front, the pelvis actually dips down and comes to a point, and it's the pubic bones and the pubic symphysis that's the connection point in the front. So in the back here, it's the sacrum, posterior side, and in the front, it's the rami, anterior rami of the pubic bones. Then we have those big holes called obturator foramen. And by the way, those holes, when we look at a skeleton, these are the largest foramen in the human body, those obturator foramen or foramen. In life, in a living person, that's actually filled with a membrane across there. There is some passages of vessels and nerves, but it's not just one big hole in you and me in a living person. So let's begin there talking about the pelvis, and there are three main bones. I highlighted them, I think, at the end of last lecture: the ilium, ischium, and pubis. These are the three bones on each side. So all three of these are on left and right, and they're fully fused late, well after puberty. So they are actually unfused bones until about age 22, 23 years of age. And then those bones, the fusions are so complete that on an adult skeleton, we can't even see the lines that separate those bones. So I'm going to now talk about these bones one at a time. The ilium is the largest of these three bones, and it makes up most of this part here, the what you and I call the hip bone, or it's also called the coxal bone. I'll write that. Largest hip bone. And there are some markings on this that are worth noting. The first is the iliac crest, so named because as the pelvis comes forward, this large ilium bone, there's a very sharp crest. I'll try to give it a thickness that comes forward like this and then wraps around to the pubic symphysis. So this is the top edge of that bowl that I just created. And we've tipped the bowl forward a little bit so you can see in the hole, and the sacrum would do something like that. And that iliac crest is this top edge that you and I can palpate. We can feel just below or just above our belt line. And you can also feel this anterior iliac spine right here in front. That's the front edge of that crest as well. There's an anterior superior iliac spine right about here. There's a posterior one that you can't see from my drawing in the back. These are all just landmarks that physicians use, that healthcare workers use, as well as landmarks that you can feel on your own body. Now, I'm going to go to a lateral view. We're still talking about the ilium. I'm going to go to a side view or a lateral view, make a new drawing here. So this would be looking at, say, the right half of the pelvis from the side, from the lateral view. So let me draw this real quickly. I'll exaggerate some of these features that we're going to talk about. This is roughly what the pelvis looks like. It's tipped forward slightly. The ilium get a new color. The ilium would exist from about this. This would be the acetabulum, which is that socket that the head of the femur sits in. And the ilium bone does something like this. Everything up here is ilium. I'll color code these. And then everything from about this point down through here is ischium. And this would be the pubis in front. This is anterior. So this is a lateral or side view. So this structure, this very large socket called the acetabulum, is the socket of the ball and socket joint that creates what you and I call the hip joint. That's the first sort of predominant landmark that we notice. And it technically, the acetabulum is only partially in the ilium, partially in the pubis, and partially in the ischium as well. That creates the socket for the head of the femur to articulate. And some other landmarks worth noting on this lateral view. This upside down V notch is called the greater sciatic notch. And it's where the sciatic nerve runs through. The sciatic nerve is the largest, longest nerve, peripheral nerve. Sorry, I meant to write notch. The greater sciatic notch is a space that nerve runs through each side of the pelvis to run down each leg. Also, there are auricular surfaces, which you can see. It's more useful if I go back to my previous drawing here. This joint, the SI joint where the sacrum and ilium meet, each of these bones, both the sacrum and the ilium, have what's called an auricular surface. It's a roughened surface. That's the actual articulating surface with each bone. So the auricular surface on both the ilium and the sacrum is the area of articulation between ilium and sacrum on the posterior side of the pelvis. So if I say SI joint, it just means sacral iliac joint. That's where the initials come from. So let me go back here. Now I'm going to say a few things about the ischium. So I'll use blue since I've color coded this. The ischium is oftentimes referred to as the sit bone because that's what we sit on. That's what I'm sitting on right now, and you, if you're seated. It's thick and has rami. A ramus is just a bar-like piece of bone, flat bar-like piece of bone. And it encompasses everything in blue. And this surface down here is what you are sitting on right now if you're seated. That's referred to as the ischial tuberosity. There is also a very prominent point that sticks out from the ischium here called the ischial spine. It's a point, almost not quite as sharp as a pencil point, but it's very sharp for a bone projection. And that's where the sacrospinous ligament attaches. That's a ligament. Ligaments connect, remember, connect bone to bone. Tendons connect muscle to bone. So the sacrospinous ligament attaches at that spine and runs to the sacrum. So we've got an ischial tuberosity as a marking, as well as the ischial spine. There's also, I've exaggerated on my drawing a little bit so that you can see it. There's also another notch in this area that I'm putting a dot. That's called the lesser sciatic notch. And it's where more nerves run through. It's a much less indented space than that V groove, upside down V groove of the greater sciatic notch. And this big hole, that obturator foramen or foramen, in life is filled, this here, I'll darken it. On a skeleton, it's just a bypass, it's just a hole. You can stick your fingers through there, but in life, it's filled with a membrane and soft tissue as well. Just making sure that I've hit just about all of the markings that are worth talking about on the ischium. Now I'm going to say a few things about the pubis. In the articulated living pelvis, the pubis actually sticks forward. This lateral view that I've drawn, that's also in your book, is slightly pitched forward. In life, this bone would be pitched back a little bit this way, and the pubic bones actually come up a little bit and sit forward. They make a point, they come to a point, like I said on this original drawing, the pubic bones come to a point right in front here, the very anterior surface, and the urinary bladder basically sits within that cavity created by that anterior space. All right, let's go back here. The superior and inferior pubic rami just refer to these sections of bone here and here. So that would be the inferior ramus of the pubic bone, and this would be the superior ramus. And where they meet, and it doesn't come to quite as pointy of a point as I've drawn there, where they meet here, there's an attachment in the front of that bowl. I know I keep switching, that I'm going to highlight in red right here. That's the pubic symphysis. And that is a piece of fibrocartilage. A symphysis just refers to a type of joint, which we'll study after our next quiz next week. It's a not completely immovable joint, but it doesn't have very much movement at all. That pubic symphysis, I want you to remember, joins the two pubic bones anteriorly, and it's made of fibrocartilage. And it not only joins the front of the two halves of the pelvis, but it also becomes flexible during childbirth, during labor. And the hormone, I need more space here, so I'm going to go to a new page. The hormone relaxin is a hormone that is released during labor, and it actually softens that pubic symphysis and makes it more movable, more pliable to accommodate some stretching for the birth of the child, particularly the head of that child. And finally, the pubic arch. When next I'm going to describe to you the differences between the male and female pelvis in general. The pubic arch is one of the differences. It's actually an angle between the two pubic bones. So let me draw that really quickly. There's the obturator foramen. Here's the pubic bone coming forward. I just used red because I happen to have that in my pen. There's the pubic symphysis. Here's the other pubic bone coming forward. There's the obturator or obturator foramen. This angle or pubic arch or angle refers to this angle right here in front. And it tends to be wider in females like this than in males. And so that leads me into the next discussion of talking about pelvic structure and the differences. There's something called pelvimetry. It's an E, which is just the measuring of pelvic structures and angles through ultrasound. Oftentimes, pregnant women undergo ultrasound not just to examine the developing fetus, but also to examine the pelvic structures of the mother. And it can be determined, everybody's pelvis is different, and it can be determined fairly early on in pregnancy if the mother's pelvis will accommodate for natural childbirth through the birthing canal, or if a cesarean section is mandated due to the narrowness of the channels. So that brings me to our next topic, which is, I'm just going to write false versus true pelvis. If we go back to my first diagram really quickly, and this bowl structure that looks somewhat like this, and that it's a bottomless bowl. There's something called the pelvic inlet, which would be the top of the bowl, and the pelvic outlet, which is the bottom of that bowl. Also, there's an imaginary line created, traced around near the pelvic inlet, and it actually sits right, that line, imaginary line, let me get a new color, runs right about here around the pelvis, and everything superior to that line is called the false pelvis, and everything inferior to that line is called the true pelvis. So the true pelvis sits lower than the false pelvis, which would sit higher in that structure, is the point I'm trying to make. So let's go back to the comparisons of false versus true now that you know what they are. So the superior and inferior regions of the pelvis, the true and false, are defined by something called the pelvic brim. And the false pelvis would be superior to that pelvic brim. And the true pelvis would be inferior or below that imaginary line. And there are different structures that are found within this area than this area. And that's what I'm going to highlight. In the false pelvis, I'll rewrite them again. In this area that's superior to that imaginary line, in the upper region of the pelvis, we find the lower intestines. And in the female, that's where the uterus and ovaries and uterine tubes are located. The reason I'm just writing tubes is because there's several different names to describe the same structures. There's uterine tubes, fallopian tubes, oviducts. Those are all the same structures. And also the top of the urinary bladder are found in the false pelvis. In the true pelvis, which is the inferior portion of that structure below that imaginary line called the pelvic brim, that contains lowest digestive structures like the rectum. That's downstream of the large intestine. Most of the urinary bladder is found down in the true pelvis. technically, when the bladder is full, it bulges upward into that false region. In the female, the lower female reproductive structures, the vagina and the cervix, which is actually technically part of the lower part of the uterus, inferior part of the uterus, are found in this area. And the prostate gland in males is also found in the true pelvic region. All right, let's highlight the main differences between male and female. If we were in person, which I wish we were, in lab, I would show you these things on examples, on true examples of a female pelvis and a male pelvis. But since we're online, I'll just list the major differences. But now that you know the anatomy of the pelvis to some degree, hopefully this will make sense. So I'm just going to write female versus male pelvis. If I just write a sentence for either male or female, just know that the opposite is true for the opposite gender or sex. So the female pelvis is typically wider, so it splays out more, and shallower, not as tall. Everybody's different. Everybody has their own shape to their pelvis, but in general, the female pelvis is both wider and shallower than the male. The male pelvis tends to be, the bones are thicker and therefore heavier. And like I said, that means that the female is thinner and lighter. That goes without saying. The acetabulum, and that is the socket for the head of the femur. It's a crater, it's a round crater-like structure that's typically located on the lateral sides of each pelvis, but the acetabulum tends to be smaller in females and a slightly different shape. It tends to be, well, it faces more anterior, so I'll say that first. Faces forward, that's what anterior means. That difference is slight but significant. So it tends to be, and the obturator, that's the big hole, the obturator foramen, is more oval shaped in females and it's rounder in males. A couple other differences: the greater sciatic notch tends to be splayed out and wider in females. That upside down V groove for the sciatic nerve that we just identified, I'm just going to write wider in females. The sacrum of the females also tends to be shorter and wider. All of these differences are basically for childbearing. Shorter and slightly wider. That means the male, I'll put female sign, the male tends to be narrower and longer, and the pelvis in the males tend to be narrower and longer as well. The coccyx in the female, there's the sacrum. If the female were facing this direction, the sacrum is shorter, wider, and more curved. And the coccyx in a female tends to be more movable and also more curved. So the coccyx in the female, I'm just going to write more curved / movable. Finally, the last thing I'm going to say is that pubic arch angle, which we already identified, that upside down V in the front, is wider in females. That's supposed to be A-N-G-L-E. My iPad just slipped on me there. The angle is wider in females. So those are the major differences. Now let's do the lower limbs and we'll be done with the appendicular skeleton. So I'll go to another board here. So in the leg, there's some there's all of the parts are analogous to the bones in the arm. Remember, there are 30 total bones that make up an arm, both in each right and left arm. There are also, guess what, 30 bones in each leg. So I'm going to write that. 30 total bones, and in parentheses I'll write each to remind you we're talking about each right and left. And it goes something like this. We can easily identify them. Here's the femur. I'm going to draw them and then we'll count them up. Here's the tibia. Here's the fibula. They rest on the ankle bones, and there are 7 tarsals. And then there are 5 metatarsals. And there are 14 phalanges, just like in the hands. There we go. And that's 1 plus 2 plus 7 plus 14. And I forgot the patella. That's what makes up 13. So there's 1 there. So there's the 30 bones that make up each leg. And we're just going to briefly examine each bone. So we'll start with the femur. That is the largest, longest, heaviest bone in the body. Now we'll identify some major markings on the femur itself. It also because of its thickness as well as its length, it's also the strongest. It happens to be the strongest bone in the body, but it does break, believe it or not. So let's just first talk about the proximal end. That means the end closest to the body. The head of the femur, which is here, articulates with the acetabulum on the ilium. That's what makes up what you and I call the hip joint. So the head of the femur articulates with the socket, which is the acetabulum of, really, it's not just of the ilium, I'm just going to say of the hip joint. That creates what we call the hip joint. Oops. Started writing the word joint before I finished writing hip. On that head is a small, tiny crater. So I'm going to draw a large femoral head here. There's a small crater like this called the fovea capitis. That little tiny pit, by tiny I mean it's typically a few millimeters wide and a few millimeters deep. This indentation is where a ligament attaches, and it's critical for the attachment to the acetabulum here. So this ball and socket joint is not just gliding freely in fluid. There's actual ligament attachment from here to here, and that ligament grabs this little pit called the fovea capitis in the head of the femur. Next, I'm writing angle of convergence. I'm not sure if this is in your book or not. In all people, all of us, the femur does this. I'm going to draw a miniature pelvis here. And here's the head of the femur on each side. The femurs, I'm exaggerating the angle. They come in medially at the knees. That's called the angle of convergence. And it tends to be greater in females than in males because the pelvis of females tends to be wider. So the angle of convergence is greater in females. What that does is it helps center the weight onto the tibia, which the femur is going to articulate with, because the tibia bones are the full weight-bearing bones in the human body. The neck of the femur, this area here, I'll draw a full femur. It tends to be the area that breaks most commonly in a fractured hip. So even though the pelvic bones thin a lot as we age, and they are still vulnerable to fracture, more often than not, hip fractures occur in this neck area of the actual femur. I have never had a full hip fracture, but guess what? I have had a full hip replacement. It's due to an old athletic injury. And here's what happens during a hip replacement. Arthroplasty, it's called. So in my hip, my right hip, here's what surgeons did. There's the acetabulum. For different reasons, usually osteoarthritis. So there's a layer of hyaline cartilage that coats this head. And there's also a layer of hyaline cartilage called articular cartilage that coats the acetabulum for free gliding. In many people, most people who have to have a full hip replacement, it's due to the wearing away of that cartilage and bone starts grinding on bone. In my particular case, due to trauma and injury from many years ago, there were holes or pits eroding away the head into the head of my femur, and fluid was accumulating in here and causing a lot of pain. Here's what surgeons do so if you ever hear of a full hip replacement, here's what's done. The bone gets cut off right here. So the neck, low down on the neck of the femur, the bone gets sawed off, and then a titanium neck, new neck, femoral head, and this is all metal. Then it's on a titanium spike that gets hammered down into the medullary cavity. Not even halfway down, but far enough that it's kind of creepy for me to think about. So everything in red now is titanium, and then a titanium plate that's coated with a plastic also gets screwed to the surface of the acetabulum here. So when you look at my hip, my right hip on x-ray, you can see actual screws penetrating through the bone. If that's the thickness of my bone there, the screws go all the way through into that space. That's a full hip replacement. So the head is fully removed, the neck, and then there's a titanium spike going down in the medullary cavity, and then this acetabulum gets resurfaced with titanium and a Teflon-like plastic for coating. On the posterior side, I'm gonna identify some of these markings. The anterior side of the femur is relatively smooth and uneventful. So on the front side, we can still see the head, the neck, this area here, and the diaphysis, the shaft of the bone. But on the back side, it tends to be more interesting in terms of anatomical features. So now I'm going to flip the head over, and we're going to look at the posterior side of the femur. There is a rather large prominent bump here called the greater trochanter. A trochanter is like a tubercle, only it's bigger. Trochanter. And there's another bump down here called the lesser trochanter. It's slightly smaller and also below the greater trochanter. That's where it gets its name. Those are very large, prominent bumps on the femur. It's purely for muscle attachment of tendons. So we have all sorts of hip muscles, gluteal muscles, buttocks muscles, and thigh muscles attaching at these points. Why? Because we are bipedal. We stand and live on 2 feet. We stand, walk, jump on 2 legs, unlike any other mammal on the planet. And so this joint has to be extremely strong. And the more that the tendons pull on these areas, the larger the bone grows in those areas. So somebody like a runner, sprinter / marathon runner would have probably greater trochanters or larger trochanters than you and I have if you don't happen to be a runner. There's also a space between these trochanters and a gluteal tuberosity, which is what I'm drawing now by this V. I'll label that. That's where the gluteal muscles really attach, most of them. Gluteal tuberosity. Remember, this is on the posterior side. Don't want you to forget that. So if I ask you on quiz day, the true or false, the trochanters are located on the anterior side of the femur, that would be false. It's posterior. The gluteal tuberosity is also on the posterior side, and the front of the femur is very rounded and smooth, very smooth. The posterior side, the back side of the femur, then there's this fairly sharp crest that rises in the middle of the femur called the linea aspera on the back side. And many of the thigh muscles and hamstrings actually attach all the way down this crest. And it enables us to flex actually flex the tibia. And as we go down, I'm gonna have to go to a new drawing, so I'll get rid of my hip replacement here. As we go down to the distal end of the femur, most of the interesting business is on the posterior side as well. So this is the distal end at the knee end. 2 big bumps are prominent on the end called condyles, and there's a groove between them. It's not a hollow groove, but it's a space that you can almost fit your little finger into this groove right here. These condyles are called medial and lateral condyles. The medial, meaning toward the midline of the body, is on the same side of the femur as the head. So I'll label this one medial condyle, and this one the lateral condyle, which would be on the lateral outside of the knee. These condyles articulate with the medial and lateral condyles of the tibia, which I will do that bone next, but that's the lower leg bone. And this space between the condyles is called the intercondylar fossa. Inter means between. Condylar just means condyles. And fossa means groove. Now, there are bumps on these condyles. There's a raised rough surface on the lateral and medial edges of these condyles called epicondyles. That just means on top of a condyle. So this would be the lateral epicondyle. This would be the medial epicondyle. They sit on top of the condyles. And finally, there's something called the adductor tubercle I'll write that out, which is superior to the medial epicondyle. There's a prominent bump on the medial side here. I'll color that in a different color. And that's called the adductor, ADD, the adductor tubercle, sorry. What's the difference between a tubercle and a condyle? A condyle is something that actually articulates with another bone. It's typically a smooth surface, which on these condyles would be here and here. Epicondyles tend to grab soft tissue. Now, this is the knee joint, and it tends to be a fairly weak joint. So there's masses of ligaments, bone-to-bone connections, and tendons, muscle-to-bone connections all around this joint to stabilize it. This adductor tubercle, getting back to that, is a specific attachment point for a very great adductor muscle in the leg called the adductor magnus muscle. And that's pretty much it on the femur. Let's go on. I'll say a few things about the patella. I need to call up some new whiteboards here. So the patella or kneecap, that's singular. If I put an E at the end of it, it means more than one. And you know that we have one on the right, one on the left. This is the largest sesamoid bone in the human body. That refers to its shape. It's attached to the tibial tuberosity, which we haven't done the tibia yet. I'll tell you what that is in a moment. It's also attached to the front, the anterior surface of the femur. It's attached to the tibial tuberosity via something called the patellar ligament. This bone, it's not a true floating bone like the hyoid bone in the neck, because it does actually articulate with the condyles, the front of the condyles of the femur and the tibia. But this heart-shaped bone, sort of shaped like this, is embedded in this thick, coarse connective tissue that attaches up to the anterior surface of the femur, and this tissue encases the patella, and then it attaches down on the tibial tuberosity. Think of the top of your shin right here, below that bone. The anterior surface of this patella tends to be relatively flat, but it has these scratch markings in the bone, and that helps the fibrous tissue grab onto. So if we were to look at a patella, if you held it in your hand, disarticulated from somebody's body, you'd see these scratch marks. It looks like somebody took a nail, a sharp tool, and made these scratch marks in the surface. That's for those ligaments to also grab the patella bone itself. Functionally, here's what the patella does. It protects the knee joint. Function, I'm going to write protection. It also increases the mechanical leverage of the muscles that bend the knee. So I'm going to say it increases, that's supposed to be an R, quadriceps muscles. Tendon leverage. All that means, think this, is that when the quadriceps, which are the main anterior muscles around the femur, when they contract, it gives more mechanical advantage to flexion and extension at that knee joint, is what it does. All right, now let's talk about the tibia, which is the lower, one of the two lower leg bones. This is the largest one. Not the largest bone, the femur's longer and heavier, but this is the largest of the lower leg bones. This is also the main weight-bearing bone of the human body. All of the weight of everything above it rests on these two bones. And therefore, it's also the most commonly broken leg bone. And it tends to be complicated when it's broken. It's also the most commonly compound type of fracture, which means that the bone fragments, the bone ends actually stick out on the surface of the skin. And that's due to all the weight bearing that's going on. So it forms what's called the tibiofemoral joint, which is the knee. So that the proximal end of the tibia, let me, here's a femur with its condyles at the knee. The tibia tends to look like the letter T, like this. And so the proximal end of the tibia meets the distal end of the femur to form this knee joint. And we refer to that joint as either the tibiofemoral joint, some people say femoral tibial joint. You and I call it the knee. The anterior border of this bone comes to a very sharp crest. That's the shin, what you and I sometimes refer to as the shin blade. So the anterior tibial crest, I'm just going to say, it's what you and I call that shin blade in front. It's that sharp projection. You can feel it. It's very thin, sharp blade of bone. There's also something called the tibial tuberosity, which I'll highlight in red. It's a protrusion, a bump. If you feel your kneecap right now as I'm speaking, your patella, right below that in front, you feel this ridge, this tough, wide ridge of bone. That's called the tibial tuberosity. It sticks outward anteriorly. It's on the tibial bone, the tibia bone. And that's what this patellar ligament attaches to. Just like the femur, the tibia also has medial and lateral condyles. Let's call up a new board. So I'm going to draw a tibia bone. You know what? I'm just going to use black. It's a little bit easier. Here's the proximal end at the knee joint, the diaphysis, and then the distal ankle end tends to do this. So the tibia, this would be the medial condyle toward the midline, the inside of the bone. This would be the lateral condyle, which would be the lateral outside of the bone. And how do I know when I'm looking at a tibia that this is the medial side and this is the lateral side? Is because of this marking right here. This is called the medial malleolus. Sorry, that's two L's. Malleolus. There we go. Malleus in Latin just means hammer-like or hammer. This is what you and I call our inside ankle bone. So if you reach down and feel the inside of your ankle, that predominant bump right there. What you're feeling is this malleolus, this medial malleolus, and it's actually part of the tibia bone itself. The distal end, meaning down here, articulates with the talus, which is one of the ankle bones. So I'm going to draw in a different color the talus bone. And then I'm just going to write, I'm still talking about the tibia. The distal end articulates with talus. That's one of our ankle bones that actually bears all the weight of the tibia. The fibular notch is an area of articulation with the distal end of the fibula. I'll draw that after I spell this correctly. So there's this, the next bone that I'm getting ready to talk about is the second lower leg bone. It's this long, skinny bone called the fibula. Actually, it bumps out like this, hangs down, and that point of articulation, the fibular notch, is right here. It's a point where these two bones they articulate. There's their point of ligament attachment up here at the medial end, another point of attachment down here at the fibular notch. And just like between the radius and the ulna, there is a sheet of interosseous membrane all the way down between these two bones. So the forearm bones, the radius and the ulna, are connected at three places: one proximal, one distal, and a sheet called the interosseous membrane between the two of them. Same with the lower leg bones, the tibia and fibula. There's 3 points of articulation, one at the proximal end, one at the distal end, and then this interosseous membrane between the two. That's like for like, similar number of points of connection, and this sheet-like ligament between the two. But the tibia and fibula are a lot less movable. You can roll, you can twist, rotate your forearm almost 360 degrees. You can't do that with your lower leg. They're much less movable, and the trade-off is they're more stable because of that. But the points of connections are very similar. All right, so just to remind you, the tibia is also the most commonly broken bone. In the leg. I'll say a few things about the fibula. That is this long, let's color it in a different color so you can actually see it. That is the long tendon bone running parallel to the tibia on the lateral side of the lower leg. It sits on the outside. Everything in blue is the fibula. So it's lateral to the tibia. You know that it articulates in 3 places. I'm not going to go through that again. Its main function is that it does not articulate with the femur up here, but it does articulate with the talus, the ankle bone down here. And its main function is to stabilize the ankle. So it really doesn't help so much with the knee joint. It really helps stabilize this ankle joint down at the distal end. That's called that tibiofibular joint down here helps stabilize that whole area. There is a bump. I've drawn an arrow, I'll highlight it in red. That our outside ankle bone is actually part of the fibula. The inside, the medial side, is part of the tibia. The outside is part of the fibula, and that's called the lateral malleolus of the fibula. So we have the medial malleolus of the tibia making the inside ankle bone, and the lateral malleolus of the fibula, that's our outside ankle bone, or lateral ankle bone. Running out of white space here. I'm just trying to write ankle bone. Now let's go on to the tarsals and the toes, and we will be finished for the day. Let's go black on this one. So the carpals are the wrist bones. We already talked about those. The tarsals are the ankle bones, and there's 7 in each foot. And I'm gonna list the names of those, and I'll pictorially show you how they're arranged as best I can. There's diagrams in your book as well. So let's just list the names, and then I'll show you how they're arranged. First is the talus, T-A-L-U-S, then calcaneus. This is, let me highlight something about the calcaneus. This is the largest, by far the largest of the ankle bones. That's the heel bone, by the way. There's a bone called the navicular. There are 3 cuneiform bones. That's C-U-N-E-I-F-O-R-M. So there's 3 cuneiforms, and they're just called the first, second, and third cuneiform. And finally, there is a cuboid. Now I'll attempt to draw how a foot is arranged from a bird's eye view. And we'll do it sort of as though we're looking down at our, let's say, our right foot. The talus bone sits highest, most superiorly on top of the other ankle bone. So this would be the top, and this area here articulates with the tibia. So you're looking straight down at your foot. This would be the talus. I'll put a letter T on it. The calcaneus, the heel bone, is slightly underneath it and lateral to it. And so there's the big heel sticking out the back, your heel. This would be the calcaneus. It's underneath and posterior to the talus. The navicular tends to be I'm exaggerating the space between them. So I'm going to write an N in here. It tends to be this horizontal bone. And then the cuneiforms sort of go 1, 2, 3. And that cuboid is a larger bone than the cuneiforms out on the lateral side, the outside of the top of your foot. This would be the cuboid. So that's how the ankle bones look from your view if you look down at the top of your foot. And then still within the solid portion of your foot are the metatarsals. They're the first set of long bones. And there's 5 of them. And then we have the toes. So everything that I've drawn up till now is the solid portion of your foot. And then the phalanges, just like the hand, the phalanges on the big toe just go 1, 2, and then on the toes themselves, there's 3 bones. 1, 2, 3, 1, 2, 3. So we have 14, there's 5 metatarsals and 14 phalanges. This guy, the tarsal bone, is the weight-bearing bone on the ankle. And so the tibia, which is the largest weight-bearing bone in the human body, sits right on top of this tarsal bone. And the tarsal's job is to distribute the weight that's coming down from the tibia. And it distributes the weight both this way, forward, and back. So I'm going to write this out. The tarsal spreads roughly about 50% of the weight it gets from the tibia to the calcaneus, backwards to the heel, and the other 50% forward to the navicular, the cuneiforms, and the cuboid. 50%, I'm going to say 2 other tarsals. And metatarsals. And the last thing that there is the talus articulates with the tibia right on top. So let me see if I can do a lateral side view of the foot for you. That will help you picture what I'm about to describe a little bit better. So let's do that. Here's the calcaneus sticking out. Does this. The talus sits on top of it, kind of like this. Maybe slight exaggeration in my picture. So there's the talus. Calcaneus comes up underneath. This would be the lateral side of the foot. So there's the cuboid. We would just see part of the navicular here, and then the 3 cuneiforms. You wouldn't really see the third one because it's over by the big toe. So we're looking at the small toe, the lateral side of the foot, and the metatarsals do this: 1, 2, 3, 4, and you wouldn't see the 5th one because of the transverse arch, and then the phalanges start after that. So this connection between the tarsal and calcaneus, that's where that 50% transmission, that 50% of the weight sort of goes this way, and then 50% of the weight tends to move this way. The tibia up here rests on what's called, the talus has a groove, a smooth condylar surface called the trochlea, the talus trochlear surface. And we call that the I'll put this in quotes, talocrural. That just means the shin part of the leg. The talocrural joint is this joint, I'll put it in red, between the talus and the tibia. Under an extreme amount of pressure because all of the weight of the human body above it is on that joint. Finally, I'm just going to briefly talk about the metatarsals. They get their names just 1, 2, 3, 4, and 5, numbered from the big toe side, the medial side out. So we've got 1, 2, 3, 4, 5. It's the intermediate part of the foot, and it articulates medially with these bones here and articulates distally with the phalanges. I do want you to know these 2 terms. The scientific term for the big toe is called hallux. I don't know if I said this to you when we were talking about the hand, but the thumb, which would be an analogous structure, is called the pollex, Pollex. So if you see these terms, you hear me say them or you see them written on a quiz, they're just literal translation. Hallux means big toe, pollex means thumb. Now quickly, the arches of the foot. There's two different arches within our foot. Plantar just means the sole surface of the foot. There is a longitudinal arch. That runs from the calcaneus, that's the heel bone, runs from the calcaneus up through the metatarsals. So I'm just going to put through. The longitudinal arch does this. It creates this arch from back to forward. That's longitudinal. There's also a transverse arch. And that runs from the cuboid across the cuneiforms. If we go from lateral to medial, it would be from the cuboid. This is across the width of the foot, across the cuneiforms 3, 2, 1. To produce the lateral left to right across the foot arch. And the point, the functional part of these arches is to really distribute the weight. It's for weight distribution. So you know this, but we've all been alive long enough to know that this arch is actually can be quite severe. Both of them can be, and they're different in every individual. But there's a space between, that's what leaves footprints that looks somewhat like this. There's quite a large space in this area where the foot rarely touches any sort of a hard surface. And the whole point of that is weight distribution. All right, guys, I've hit the end, so let me cut my recording and then I'll let you ask questions.